therapies, now just switching gears to cellular therapies can be any, we take a cell from a patient and we genetically modify, or we don't genetically modify. And there are many kinds of cellular therapies. However, for the purpose of today's talk, I'll just focus on what we call chimeric antigen receptor, T cell. And there's also NK cell chimeric antigen receptor, which are now studied for multiple myeloma. It's of importance to note that there are now 2 FDA-approved autologous, meaning from the same patient, CAR T therapies that are available for patients in various centers. One is called idacaptogene vicleucel or Idacel, and the other is ciltacabtagene autoleucel or called Carvykti. They both target the BCMA protein on the surface of these plasma cells, and they are found to be very efficacious therapies, which are actually a godsend for patients who have seen 4 or more lines of treatments and have good responses. There are other promising candidates which are not FDA approved and they are still in the clinical trial stage, with new targets like GPRC5D, taking a CAR T from a healthy patient and giving it back to the patient, which is called allogeneic CAR T and also CAR NK. Very quick overview of how exactly are CAR T cells made. So blood if you imagine it to be very similar to stem cell transplant, you won't be far off. In fact, we collect blood from a patient over 3 to 6 hours. The white blood cells are separated and the remaining is reinfused back to the patients. The difference is that the T cells then go to a laboratory. These T cells are genetically modified to express, and I'll use my laser pointer again, to express this little receptor on the surface of these cells, which can identify the target that we want. The CAR T cells then multiply in the lab, and the whole process takes around 1 to 2 months. And then they are reinfused back to the patient after lymphodepleting chemotherapy. These CAR cells, which now have a new receptor to identify the cancer cell, then goes and binds to the cancer cell and kills them. So this is a nutshell of how the CAR T cells function. So right before treatment with the CAR T, we often give chemotherapy, and we also give medications to suppress any kind of responses you have, like fever or allergies, etc. Cellular therapies, they're very efficacious, but they're not really benign. They have what we call short-term and long-term complications. The short-term complications are cytokine release syndrome, and it can also have neurotoxicity, which we closely monitor in the hospital setting. There are long-term effects too, called macrophage activation syndrome, B-cell aplasia, and prolonged cytopenias, which we monitor very closely in clinic. Other complications of myeloma, which we actively look for and manage, include bone health for pathologic fractures, bone pain. The kidneys are very important to us because it determines what's the kind of dose we give, infections, hypercalcemia, anemia, neuropathies, etc. So there's a whole host of complications for which we both have treatment, and we also give preventative medications as well, which is summarized in this table.